So in this video, we'll learn about ocular symptomatology. So what are the common complaints that the patient comes to us with? And when a patient presents with certain complaints, what would be the history that you have to take? And what would be the common causes for whatever symptoms that the patient presents to us with? So the most common complaint that the patient comes to ophthalmology OPD is blurring of vision. So whenever a patient comes to us with blurring of vision, the first thing that you'll ask is since when? Since how long do they have blurring of vision? So if it's a long duration, you know that it is something which is slowly progressing or something which has nearly not bothered the patient and that's why he has not come to you. Short duration within 1 hour or 20 within 24 hours patient comes to you. So that means it's a significant loss of vision. And probably these are also conditions which has where the patient has noticed something and has come because it is bothering him and he has come immediately to you. So onset, whether it's a in sudden onset or a insidious onset. What do you mean by sudden onset? Again, something which is within 24 hours. The patient notices a significant drop in vision and he comes to the hospital because it is affecting and bothering him. Whenever a patient comes to us with sudden onset of vision, there are only two things that you'll be thinking of, vascular or neurological. If it is vascular, what are the causes? It could be a central retinal vein occlusion, central retinal artery occlusion, vitreous hemorrhage, central serous retinopathy, central choroiditis. If it is neurological, it could either be optic neuritis or retinal detachment. The onset can also be insidious onset. That means when a patient says he doesn't know when it started, but roughly says maybe a year, or maybe 6 months, you know, then you would probably call it as an insidious onset. The causes could be refractive error, senile cataract, primary open angle glaucoma, diabetic retinopathy, age-related macular degeneration, corneal dystrophy or degeneration, and pterygium. But here in the last two cases, patient will tell you that he has also noticed some change in the black part of his eye, or he has seen a fleshy growth on his eye. So along with diminution of vision, he'll also complain of these things. Okay. Progression, whether it is static, so his patient has noticed reduced vision and it has remained the same, whether it's steadily worsening over time, he noticed a drop in vision and is slowly progressing to further reduce, or improving. Patients can also say that they noticed a drop of vision, it reduced for some time and again started improving, and within 1 week they're fine again. So what could be the causes? Static, saw a reduced vision and it has remained the same. Central retinal vein occlusion, central retinal artery occlusion, retinal detachment. This is what you'll be thinking of. Steadily worsening. This would also be the same conditions where the onset was insidious onset, gradually progressive loss of vision. We'll be thinking of senile cataract, primary open angle glaucoma, diabetic retinopathy, age-related macular degeneration, corneal dystrophy or degeneration, and pterygium. Improving. What are the conditions where the vision drops and then improves? Optic neuritis. This is a very typical history of optic neuritis. Patient notices sudden reduction in vision, worsens for 1 or 2 days, and then again starts improving. Multiple sclerosis or demyelinating disorders present like this. What is the pattern of loss of vision? Whether it has been constant, okay, again you'll be thinking of something which is gradually progressive loss of vision, or it is intermittent. Patient says that he notices a reduce of vision, improves, and again it is an intermittent pattern, on and off pattern. So that is when we call it as transient loss of vision or amaurosis fugax. So what would be the causes for transient loss of vision? It could be either atherosclerosis in carotid artery, which could lead to vertebrobasilar artery insufficiency, giant cell arteritis also presenting like this, or impending CRVO. Atherosclerosis of carotid artery can be associated with impending CRVO, and these patients can present with transient loss of vision, improves, and if you don't identify it, can lead to a full-fledged CRVO and patient can lose vision. Or cardiovascular abnormalities like valvular defects, arrhythmias, patient can present with transient loss of vision which improves within few minutes or few seconds. Migraine is the most common cause of transient loss of vision. where patient either presents as a says that there's a transient loss of vision as a aura, or following headache that he says as scintillating scotoma, or transient loss of vision which lasts for few minutes or few hours and then improves spontaneously. So in all these three conditions, there is vascular insufficiency resulting in retinal ischemia and thus resulting in loss of vision, which improves once the retinal ischemia is reversed and again the vision improves back. There's a condition called as gaze-evoked nystagmorosis. So, which is usually patient looks in one direction and he sees a reduced vision. This is whenever a patient comes to you with such a condition, the most common association is optic nerve sheath meningioma. You have to look thoroughly and investigate if there's any optic nerve sheath meningioma. When a patient comes to you with sudden painless loss of vision, okay, so you'll have to ask about laterality of the diminution of vision, whether it's unilateral or bilateral. If it's unilateral, what could be the cause for sudden painless loss of vision? Central retinal vein occlusion, central retinal artery occlusion, retinal detachment, vitreous hemorrhage, central serous nephropathy, central choroiditis or papillitis can present with unilateral sudden painless loss of vision. If it's bilateral, you will be thinking more in terms of bilateral occipital infarct or metabolic toxic optic neuropathy, ethambutol or methanol toxicity, or diabetic retinopathy. Diabetic retinopathy can present with bilateral painless loss of vision, but usually it is asymmetric. One eye is worse than the other. Now, blurring of vision can also be associated. What are the associations of blurring of vision? It can be associated with pain. So when you see pain, blurring of vision associated with pain, in either iridocyclitis, herpetic keratitis, corneal ulcer, mechanical or chemical injuries, angle closure glaucoma, endophthalmitis or panophthalmitis and orbital cellulitis. Um, so the blurring of vision can be varied, can be mild blurring of vision to like in iridocyclitis or in severe, almost PL negative kind of blurring of vision in case of orbital cellulitis. Glare or photophobia, what blurring of vision associated with glare or photophobia. What do you mean by glare and photophobia? When we say glare, it is intolerance to bright light. So this is even seen in normal people. I mean, a normal individual, when he's exposed to intense light, he can experience glare, right? A person presenting you with blurred vision, but more glare. He says he's more troubled at night by the incoming vehicles, the light of the incoming vehicles. Then you will probably be thinking of posterior subcapsular cataract, corneal edema, central corneal opacities, aniridia or ocular albinism, where there's increased entry of light into the eye. These can present with intolerance to bright light, glare. What is photophobia? How is it different from glare? This is intolerance to normal light. A normal person can tolerate this light, but these individuals say that even some amount of light is also they're not able to tolerate, and it is painful. Okay, if you see the patients in your OPD, they are trying to avoid light, they're trying to put their head down and sit in the OPD. And this is more of an objective kind of photophobia, where it is evident that the patient is intolerant to light. So when you see this, the thing that you have to think about is only three conditions, that there is ciliary spasm. And what can cause ciliary spasm? Iridocyclitis, keratitis, or angle closure glaucoma. Okay, so blurring of vision can be, the patient can also, the next thing that you're going to ask is whether it's more for distant objects or more for near objects. What do you mean by more for distant objects? So the near vision is good. Something nearby, close by, they can see, but for distant objects, they have reduced vision. So the common conditions are myopia or nuclear cataract or second sight. Myopia is otherwise called short-sightedness, where the patient is comfortably can see near objects but is troubled with distant objects. In nuclear cataract or second sight, it's where we see in nuclear sclerosis. There's a in the nuclear sclerosis, the refractive index of the nucleus increases. So when the refractive index of the nucleus increases, it results in index myopia. So a patient who was presbyopic, imagine, he was using glasses for near vision. Now 50, 60 years, he suddenly realizes that even without his near vision glasses, he can see. but is probably is developing nuclear sclerosis and is having index myopia. This is otherwise called as second sight. So here the patients with nuclear cataract, this is the history that they come with. They say that they have blurred vision for distant objects, but for near vision, suddenly they are can see even without glasses. So then you should suspect nuclear sclerosis. Whenever they come with diminution of vision more for near objects, where they're better off with distant objects they can see clearly, but this near objects they are having problem. The most common condition that you'll think about is presbyopia, which is a physiological condition. Here, the patient has reduced accommodation. After 40 years, you'll see that they are difficulty in near vision, but they have a good distant vision. Hypermetropia, they have reduced vision for both distant and near. Remember, it's not only for near. Okay, so don't say when there's distant reduced vision for more for near objects, please don't say hypermetropia just because you said myopia more for distant objects. The next thing is diurnal vision, whether it's the diminution of vision is more during day or more during dim light. If it's more during day, otherwise called as day blindness or hamarlopia, what could be the causes? So what happens during day? Pupil constricts. In bright light, pupil constricts. So there's any lesion in the pupillary axis, on the visual axis, central corneal opacities, central lenticular opacities, anterior subcapsular cataract, posterior subcapsular cataract, nuclear sclerosis, anything affecting the cones or the macula, macular edema, age-related macular degeneration, cone dystrophies, all these things can cause hamarlopia. What happens during dim light? Otherwise, diminution of vision during dim light, otherwise called as nyctalopia or night blindness. What happens during dim light? Pupil dilates, right? So if the patient has a peripheral lesions, peripheral cortical cataract, now the patient experiences more diminution of vision in dim light. So any peripheral cataract, or what are the photoreceptors active during dim light? Rods. So any rod dystrophy or rod dysfunction. So peripheral cortical cataract or rod dystrophy like retinitis pigmentosa, rod dysfunction seen in vitamin A deficiency can all cause nyctalopia or night blindness. So that's about a blurring of vision. So you'll ask about the onset, duration, progression, the pattern associated with pain or no pain, whether it's unilateral or bilateral, whether it's associated with more in the dim light or bright light, whether it's more for near or far, and associated symptoms of pain or glare or photophobia. The next symptom, visual complaint that the patient can come with is double vision. Okay, double vision or otherwise called as diplopia. So again, double vision, when the patient comes, you'll ask whether it's monoocular or binocular. Monocular, when we say whether when patient close one eye, also he can see. So if the patient says he has double vision in the right eye, if you close the left eye, also the double vision persists in the right eye. Okay. So what could be the causes? Polychoria, multiple pupils in the right eye. Very rare, but it can happen. Iris holes, traumatic iris holes, they can present with. Again, it's similar to polychoria where multiple images fall on the retina. Irregular astigmatism, like in keratoconus because of cornea, or because of irregular astigmatism happening in the lens, like in a senile immature cataract or incipient stage, they can present with polyopia. Subluxated clear lens, like in ectopia lentis, like in Marfan syndrome. Displaced IOL or displaced contact lens, also they can present with monocular double vision. When a patient says binocular double vision, that means when he keeps both eyes open, only then he has double vision. When he closes one eye, double vision disappears. So when a patient says this, they will come to you with this complaint. When a patient says this, you'll have to be thinking of something which involves the extraocular movements. Okay, so what could affect the extraocular movements? Either paralysis of the muscles or restriction of the muscles. Paralytic squints, like in sixth nerve palsy, fourth nerve palsy, or in case of a third nerve palsy, can present with double vision, binocular double vision, or thyroid eye disease or orbital wall fracture with muscle entrapment can cause restrictive pathology or restrictive strabismus and cause double vision. The third symptom of vision that the patient comes to us with metamorphopsia, that is distorted images. Patient says that he has distorted images. Whenever, especially when a patient has uniocular pathologies, he says with one eye, the images appear straight, a straight line appears straight, whereas with the other eye, the same line appears crooked, okay, or distorted. Or with one eye, the patient sees that the images are either small or appearing large. So whenever a patient comes to you with this symptom, the only thing that you're going to think of is macular lesions. It could be central serous retinopathy, age-related macular degeneration, diabetic macular edema, macular hole, or macular scar. Patient can also come, as I told you, can come with micropsia, where the images appear smaller than they are. So when does this happen? Cones in the fovea are separated due to collection of fluid. So imagine in a normal individual, some object was casting an image on 5 cones. Now, because the cones in the fovea are separated because of fluid between the cones. So the same image now is falling, instead of falling on 5 cones, is falling on 3 cones. What does the brain perceive it as? It perceives it as a smaller image. So where do you see micropsia? You see it in macular edema or central serous retinopathy. Macropsia. Images appear larger than they are. So here, cones in the fovea pull closer due to scarring. So the image, the object which was casting an image on 3 cones in a normal individual, now is probably casting an image on 5 cones because of 4 cones are pulled together. So what does the brain perceive it as? It perceives it as a larger image. So you see macropsia in macular scar. So in summary, whenever a patient comes with visual problems, what are the visual problems that they come to you with? Blurring of vision. When the patient comes with blurring of vision, you'll ask about the onset, duration, progression, pattern, intermittent or constant, blurring of vision more for near or far, associated with pain, associated with glare or photophobia, and diurnal variation. The other symptoms that the patient can come to you with is double vision or diplopia. Either it can be monocular or binocular. And metamorphopsia, the distorted images, micropsia or macropsia. So thank you very much.